Hello, everyone. Welcome to Session 5 of the Oxygen Therapy and Critical Care Case-Based Series. Today's topic is Basic ICU Care Considerations. With us today, we have Dr. Eugene from the Institute of Medical Education and Global Health, Dr. Celestine Seneza from the Centre Hospitalier Universitaire de Butare, and Dr. Jean-Paul Mvukiyehi from the University of Rwanda. Just before we begin, we have a couple of housekeeping items. As always, our programming is based on a foundation of love and respect. Please respond kindly rather than react if you disagree with something. It is everyone's responsibility to keep the webinar a safe space. We will be using the chat function for question and answer. This button is at the bottom of your screen, so please send all questions through the chat box and feel free to introduce yourself. If you have sufficient internet connection where you are, you're welcome to turn on your video, position your webcam effectively to show your face if you're alone, or to capture the whole group. If you have limited internet connection, keeping your video off may help. If you have any technological issues, please send us a message through the chat and we will be happy to help you. The session today is being recorded and your attendance is consent to be recorded, so thank you. And please be mindful of infection prevention and control. Try to limit the number of people joining from one gathering place and practice physical distancing. And with that, I'll hand it over to Dr. Eugene.
Thank you very much, Arana, for a good introduction. So today we are going to discuss about the basics of ICU. And I will be with like Dr. Celestine and Dr. Jean-Paul. So we'll be able to discuss about that and also to share our experience. So we'll keep in mind that most of our participants are not ICU experts, but also they are not working in ICU every day. But I think this we can have like translate what we'll be discussing towards what they do at a regular basis. I think sometimes be like called for transportation of sick patient. They manage their department, and the skills for to have a good ICU can be translated to their regular work. So, but also we have to keep in mind that we need to have continuous professional development and also to think about quality improvement in our regular work. So I think this will be an interactive session and I invite everyone to participate. Every time you can stop us, you can write in the chat, you can speak up, you can ask all the questions. There is no wrong question or wrong answer. So without any further ado, I think we can start. And let's see if Jean-Paul or Celestine has something to add. Anything to add, Celestine?
I think it's okay, Gene. Can start.
Okay, Jean-Paul, anything to add?
Yes, you can start.
Okay, very good. So for today, here are the objectives. I think the characters are very small. Yeah, this is very nice. So for the objectives for today, we need to be able to identify the minimum standards to have a good intensive care unit. So we'll be able to discuss about key healthcare providers in the intensive care unit, the types of monitors that we may need. And the good thing is that most of them are similar to the monitors we need in anesthesia. So, and then we need to discuss about specialized equipment that we may need. We will discuss about common indications for ICU admission, and I would like everyone to think about the reasons for transfer for high quality of care or for higher level of care. Then we need to understand the common complications in ICU, and then we'll discuss finally the ICU care bundles for ICU patients. So in order to do that, you can go down and start with the case. Let us keep in mind that Mr. T is a 46 years old male with history of obesity and type 2 diabetes who presented to emergency department after 3 days of shortness of breath, cough, and fever. On exam, he appears well. His breathing in non-robot breathing, he's speaking in full sentences. He has a past surgical history of cholecystectomy in 2012. He doesn't smoke. He doesn't drink or use drugs. He lives with multiple family members and he's an engineer. You see these vital signs. The heart rate is 98. The blood pressure is 127 over 63. The respiratory rate is increased at 30. The temperature is normal at 36.5 degrees Celsius. And the saturation of oxygen is 87, which is low. He's placed on non-rebreather mask at 10 liters per minute, and his saturation of oxygen has improved to 92%. The emergency room physician called for ICU physician. So keep that in mind. Then we can go down and discuss about ICU. What is an ICU? You see there are multiple answers. Probably people can just write in the chat what they think. For you, in summary, what is an ICU? I'll give you about 30 seconds to write what do you think is an ICU, especially that we have shared some of the articles discussing that topic. Yeah, please write in the chat. Okay, very good. So a unit where the patient needs a special and close monitoring. Okay, that's good. High level of care. Good. Okay, one more and then we can continue. Okay, everyone is saying about high level of care. Okay, we can go down and see the definition of ICU. Okay, keep going down. So the World Federation of Intensive Care, Intensive and Critical Care, define ICU as an organized system for the provision of care to critically ill patients that provides intensive and specialized monitoring and multiple modalities of physiologic organ support to sustain life during a period of life-threatening organ system insufficiency. Okay, that's the definition from the World Federation of Intensive Care and Critical Care. I think it's not very far from what most of the people said, including like high level of care, uh, monitoring and management of critically ill patients. But also we can see that it's a well organized system, and also you need specialized medical and nursing care. So for me, that means you need a high level of training and also high level of equipment. So Celestine, any addition to this?
I think, as you said, ICU for me, I understand that it is a well-organized system where you manage a high critically patient, and then most of those patients need really a close monitoring, and they need specialized healthcare providers, nursing, doctors. I think it is really a complex environment where you need a close monitoring of those patients.
Yeah, thank you. So before we move to the component of an ICU, so my another comment is that the care given while the patient was seen for the first time have like a huge impact on the patient outcomes. So that's why I think this talk is even important to everyone. Because if we are like in our context, if we are seeing the patient at the district level, and then you are sending the patient to a teaching hospital, for example, or myself or Celestine will be. So what you do will impact the patient outcomes in critical care. So that's why I think we should pay attention to like the management or the support of those systems which are affected for this patient. So Jean-Paul, any addition to that? For you, what is ICU? Jean-Paul.
I'm saying that obviously an ICU, as you mentioned, Celestine mentioned, just there is a component of critically ill patient, most of them with life-threatening condition, who need the monitoring, support and treatment, close monitoring or support and treatment, like that, just in summary.
Yeah, thank you. So let us ask our participants a simple question. A simple question. So, which of the following are the standard component of an intensive care unit? So you have one, continuous monitoring, two, specialty trained healthcare providers, three, system of delivery, system of delivery of timely critical care, specialty patient care equipment, rapid access to diagnostics and therapeutics, or all of the above. So I see that Arana has shared the poll, so people can just fill the poll. Okay. That's good. Okay, others also can fill the poll. I have a few seconds. Complete the poll. Very good. Okay, yeah, I think we're happy with the participation. So as you can see, most of the people said all of the above, which is the correct answer. So you need all of those things. You need continuous monitoring, healthcare providers who are well trained, um, a good system, and also equipment, therapeutics, and diagnostics. So, but for me, the most important thing first is to have like specialized team, like trained people, because then they can advocate for all those other things. So, yeah, we can continue to the next slide. So keep in mind our patient. So despite 10 liters per minute of oxygen, Mr. T SpO2 decreased to 89. and the respiratory rate increased from 30 to 32, and he's only speaking 2 to 3 words at that time. So, does this patient need an ICU? Why or why not? So let's start with that simple question. People can write in the chat. Why do you think this patient needs to be admitted in ICU? So most of the time we say it's for like to support impending failure of some systems. Which system is most affected? So why do you think this patient need ICU? Okay, you have just a few seconds to answer that, and then we move to the next question. Okay, Jacques said ICU because he has impending respiratory failure. Yeah, the other one said, yeah, he can have respiratory failure anytime. Okay, very good. The level of consciousness is being decreased, and there's respiratory failure. Okay, I think we're happy with the answers, and I would agree that he has impending respiratory failure, therefore he may need respiratory support. Okay. Um, the other question is, which of the following are essential staff for an ICU? I don't know, do you have a poll for that? So the first, yeah, you can answer the poll there. So do ICU nurses, physician, respiratory therapist and physiotherapist, pharmacist, cleaning staff, all of the above. You can choose one of those. Very good. So most of the people think we need all of the above. So, and I think this is a point for a good discussion. And I would like Celestine and then Jean-Paul to to tell us what they think about the challenges we face in our context of not having a respiratory therapist and a physiotherapist at a regular basis and a pharmacist. Because I think we have nurses, even if not all nurses are trained in the critical care. And then also have some physician, even if we don't have enough. But I would like to ask them to discuss about the need of respiratory therapist and the physiotherapist and the pharmacist. And after that, we may discuss also like the involvement of non-physician anesthetist in ICU. Those are two questions. Celestine, you can go first.
So thank you very much, Eugene. So as you have seen in previous slide, ICU patients, those patients are really in a critical condition. They have a life-threatening condition, which really need a multidisciplinary team approach to manage well those patients. So I think to have all of those staff, personnel, medical personnel, it it will help those patients. For example, in our context, we don't have a trained nurse in ICU, but if you have a trained nurse in ICU, the care the way they are providing care to those patients, it will be better than a jail nurse, for example, because those patients are really in a critical condition. The same as don't have a respiratory therapist, for example, for example, for physiotherapy. So we try to manage those patients with our general physiotherapist. But if you have a respiratory therapist, so it will be better. They will manage very well those patients. as most of them they are having respiratory issues, and also pharmacists, they are very essential in ICU to manage medication, and also other physician, because if you are working alone in ICU, you need other physician. For example, maybe we need a physician, a nephrologist. If the patient is having an acute kidney injury, you need a nephrologist, you need a cardiologist. So I think to manage a patient in ICU, you really need a multidisciplinary approach.
Yeah, Jean-Paul, you can go ahead, and also, if possible, you can add your experience in the US so that you can compare in the settings where they have these people, and then to our context, and then what is the gap? What can we do about it?
Thank you. Actually, when I'm comparing what I saw in the US and what we are doing in our setting, uh, it's totally different in terms of staffing. Staffing, because of we are still lacking those staff. Like when let me give you an example. A ward lounge, an ICU ward lounge in US, which was composed by doctors, ICU doctors. If they are, so number one, there they have subspecialty, surgical ICU, medical ICU, cardiac ICU. There are different type of ICU, and people they are trained in subspecialties. For us, we have a combined ICU where we don't have people with this subspecialty. That's one of the difference. Again, for the nursing, they have trained nurse, especially in ICU, critical care nurses in ICU. And they have those respiratory therapists. They have also the pharmacist during the ward round. The pharmacist is there, infectious disease person is there, nutritionist is there. It's a during a ward round, you may have like 10 people with different subspecialty, which is different in our setting, where I do a ward round in ICU as a doctor with nurse and students only. Nutritionist will come later, social workers will come later to resolve social problem. Pharmacist will not come. If I have a patient with infectious disease, we don't have microbiologist, we don't have infectious disease specialist to have all this team on board. So we are having a lot of challenge when you compare to other setting. However, in our setting, we have the way of adapting the few resources we have, the nurses, the doctors. We are trying to combine these subspecialty. As an anesthesiologist, I have to know much in pharmacy, I have to know much in microbiology, I have to know much in nutrition. Those things I'm not supposed to do it, but as we are having the gap, we need to fill the gap. That's what I can say.
Yeah, thank you, Jean-Paul. Interesting. So, but those gaps may bring some opportunities. We may think about like in our like continuous professional development. Who knows? Maybe in the future there will be like respiratory therapist programs at maybe a bachelor level or a master's level, where people who have like experience in airway management, non-physician anesthetists, also can join those programs because I think they may be even more comfortable, like in managing those critically ill patients in ICU some of them are interested. I don't know what certain think about that in the example.
Exactly, I think so.
Okay.
Maybe what I can add about Nani, our colleague anesthetist, for ICU, I guess they are better even than these nurses who are working in ICU in terms of airway management and some pharmacology of the medicine that we are using, especially vasopressors and what. But I feel like there is still a gap from them. There is a gap of basic nursing. So ICU require basic nursing. There is a kind of nursing component, a kind of like the way of this kind of nursing. I didn't do nursing, but there is a kind of nursing inside than skilled in airway management, than skilled in this monitoring and the pharmacological medicine used in ICU. So maybe if this happen to have like
Jean-Paul, are you there? Okay, we lost connection with Jean-Paul, but I think that was a good discussion. There's no right or wrong answer. But what I was thinking about was on the respiratory therapist side, because they don't do any nursing work. They just do, they manage the ventilator machine, then they provide the support to be able to win patients the, the ventilator. And as you know, the more you stay on the ventilator, the more risks you have, especially ventilator associated with pneumonia and other complications. So, and also because we don't have enough, also ICU specialists, once you have other people who have that knowledge, then you can manage more patients at the supervision level than being on the bedside for every single patient. Yeah, so it's something just to think to keep in mind for discussion. I think we can continue to the next slide. The other question is, which of the above providers could improve the care of Mr. T? How and why? So you can remember the people we have. So we have ICU, nursing, physician, respiratory therapist, physiotherapist, pharmacist, um, cleaning staff, so all of the above. What do you think? Which of the above um, could improve the care of Mr. T? You can also write in the chat a number. Is it one, two, three, or six? You see what you think. And you can also say one. Why do you think this staff will make an impact for our patient?
For me, I can choose all the above.
Okay, yeah. I think we can hear from Diedone, Rutikanga. So yeah, Diedone Rutikanga, why do you think ICU nurses will make the bigger impact for this patient? We can unmute him and allow him to speak. Diedone Rutikanga, are you able to speak? Okay, yes, Senator. Why do you think like respiratory therapists and physiotherapists you will speak next after Titan?
It is all the above, I see. All are able and to support the patient in ICU. ICU trained nurses, ICU trained physician, all the above, not one.
Thank you. That makes sense. Uh, yes, Senator. Do you have a different view because you said you think respiratory therapists have bigger impact?
Yes.
I think people are slow to respond, but the message here is that ICU can't be done by one person. ICU is a teamwork and it's a solution. So the most important part is to be able to involve each specialist, each team, and coordinate the care to provide the highest care possible. Let's check if everyone is unmute. Okay. Very good. So we can go to the next question. I think everyone understand that in ICU we need to have a good teamwork. So let's continue with the case. So keep in mind that the patient was deteriorating. Now you have missed, he's transferred to the ICU. He's placed in isolation with negative pressure as a person under investigation for COVID. He continues oxygen therapy with non-rebreather mask, but the flow has been increased to 15 liters per minute. So which monitors would you put on the patient? Which of the following is not a patient monitoring requirement found in most of ICUs? So we can go down and see the list there, and then you can answer the question. So among all those monitors, which one is not a required monitor? Yeah, you can just choose among those. You can fill the poll there. You have electrocardiogram, pulse oximetry, arterial blood pressure, transcranial Doppler, respiratory rate, or no one of the above are required. Good. Okay, interesting. Someone thinks we don't have to check the blood pressure. No one of the above are required. So no one of the above are required means that you don't need any other monitors. I don't think that someone understood the question. But as you know, there are essential monitors, including EKG, pulse oximetry, blood pressure, and the respiratory rate. So those are essential monitors. And for anesthesia, sometimes we add temperature. So I think those are essential monitors we need to keep in mind for our ICU patients. Let's go down to the progress of the case. So after admitting the patient in ICU and increasing the oxygen to 15, the heart rate has been increased to 102. The blood pressure is decreasing to 117 over 52. The respiratory rate is 32. Temperature has been increased to 37.5. and the saturation is 91%. So as you can see, the oxygen saturation is not improving. So the next question is, in addition to the patient monitors, what other type of monitors are needed in ICU? Can you think about other needed monitors in ICU? Maybe we can discuss this. Celestine, do you think we need something else to monitor something else beyond the EKG, the pulse oximetry, the blood pressure, and the respiratory rate?
So thank you very much, Eugene. As we have discussed, ICU is a close monitoring. Maybe we should think about to do arterial blood gas to see the gas, CO2, partial pressure of oxygen, and why not? The patient is dropping BP. Maybe we should think about invasive blood pressure, because the ICU patient we need really close monitoring, because it is a patient at any time it can deteriorate. So we need to cross all those parameters closely.
Very good. Jean-Paul, any addition?
For me, I may say in our setting, actually, by having this standard monitoring, this 5 standard monitoring, if we have all those standard monitors, I think it's okay, because having SpO2, you may have the partial pressure of oxygen in the blood, even if you don't have an ABG. By having an invasive blood pressure monitoring, also you may still monitoring your patient. As Celestine said, also, if you are lucky to have invasive blood pressure monitoring, that will be an added value. By having EKG, respiratory rate, and the temperature monitoring, I think that's really enough. And again, those monitors also, you should be able to know and to use these monitors by setting the alarms, the normal range, so that if anything change, they can give you an alarm, then you see what is going on.
Very good. So the other thing we can think about, if we had like enough resources, and according to the patient, some patients may require ICP monitoring, intracranial pressure monitoring, for example, central venous pressure monitoring, arterial line for like invasive monitoring, as you said, ABG, electrolyte, oxygen concentration monitoring in the alarm, the connection monitoring, capnography for CO2 monitoring. So there are a lot of the things people can do. Even if what we are doing now doesn't mean that we don't have gaps. That's why I think people also can connect this to continuous professional development. Because sometimes in our settings, we see what we are providing or the care we are providing, do we think that is enough? Most of the time, it's because that's what we see. But a lot have been like done. So there is also, for example, ECMO machines in any other countries. So for like extracorporeal membrane oxygenotherapy. So things have been improved, and I think that Rwanda also is on its way for like highest level of care and the better quality of care. So we need to know that all those technology exist, and that maybe we can encourage people to find ways they can improve their knowledge, and also they can go in, maybe in other countries to do further training, subspecialty training, things like that. Because this really brought me the idea of our experience, me and Celestine and other people were developing the standards of anesthesia practice. And people think like what we are doing is enough, but other people also showed like how the field has improved too much. So there's a lot uh, things that we have to improve on, and I think like there are a lot of opportunities ahead. So I don't know if someone has any question on that or any comment, either Celestine or Jean Paul or participant before we move. Okay, seems like there's no comment for now.
Yeah.
We can continue. Yeah, let's continue. Yeah, I think that's a good question here. So, what is the recommended maximum nurse to patient ratio for a critically ill patient in the ICU? You can pick, is it 1 to 4? Do you need like one nurse for 4 patients, one nurse for 5 patients, one nurse for 3 patients, or one nurse for 2 patients? Yeah, while you are answering this question, I hope you had a chance to read some of the articles we shared about the capacity of ICU. And as you remember, there are 3 levels of ICU. So there's the basic ICU, which is level 1. There's the moderate level, which is level 2. And then there is the highest level, which is level 3. And in the level 3, you would aim to have like high nurse to patient ratio. You have all the specialists, and also you have all the equipment, specialist equipment. And as you have seen in the articles, those centers are very expensive to manage. And you need like one doctor, trained physician in ICU for about 8 beds, 8 to 15 beds. So but for level 1, you may just have one trained physician, and you may have like 1, 2, 3, one nurse for 3 patients. Okay, so I can see most of the people answered that you need 1 to 2, which is I think is a reasonable ratio, especially in our context. I don't know the experience from Jean Paul now. How many nurses are we have in Utare for like the ratio from nurse to ICU patients. And Celestine can share his experience in our other team.
Yeah, thank you. My experience, recent experience to Sashibe, it is somehow variable. It is not something which is consistent. It depends on the situation. Sometimes we may have a time of where we have one nurse for 2 patients, sometimes one nurse for 3 patients, even 4 might happen. Mostly all depend on the schedule and the circumstance. Sometimes some people they are in sick leave, some others they are in circumstance leaves, and people are not available, and those who remain they have to cover to fill the gap. All is standing around about the few staff, the few nurses. We are still having a few nurses, so it is not consistent. But ideally, sometimes we have one nurse for 2 patients, which is okay. Even in my experience in the US also, I saw one nurse to 1 patient, sometimes one nurse for 2 patients. Yeah, still okay.
Okay, Celeste, thank you.
So thank you very much, Eugene. So I was reading one guidance from Australia, which recommended if you have a ventilated patient, you really need one ratio, 1 nurse, 1 bed. It's because of we know that an ICU patient, a ventilated patient, require a lot of work. They need to give medication, suctioning, changing position. I think if we need to improve quality of care of those patients, maybe 1 ratio should be reasonable. But in our context, as you know, have issue of staff. Maybe as Jean-Paul said, 1:2 ratio, it can be possible in our context. But if we need to meet the standard and to give a high standard of care of those patients in critical condition with life-threatening condition, we need a 1:1 ratio standard.
Okay, thank you, Celeste. So the other thing which really came in my mind after reading some of the recommendation from the Australian guidelines is the need to have someone in charge of quality improvement and also someone in charge of continuous professional development and to have like protected time because it's difficult to provide the care if you're not measuring the progress. So if you're not measuring like how many cases are you doing, what are the complication rate, how are you comparing what you are doing to the international standards and also to the known complication rate. I think that's important. We can translate that to our own practice. So if you're working in a district hospital, are you making any report of the number of anesthesia cases that you're doing every month? How many complications? Why are you having some complications? How can you improve that? So how many continuous professional development opportunities are available? How can you improve that? So those are the things people can think about. So we can continue now to the next slide about the equipment. So which of the following specialty equipment is least likely needed in a care for acute? So among those 5, which one is not important for now? So you have airway equipment, mechanical ventilator, you have bag mask ventilation, external ventilator drain, and suction apparatus. Among those, which one is not needed? Very good. Yeah, I think most of the people they're getting the right answer. Um, I see someone saying about bag mask ventilation. Imagine this patient has a respiratory failure. You may need to do the intubation, and then you may need bag mask ventilation. And, yeah. So let's continue with the next question, which is what other specialized equipment are helpful in ICU patient?
So maybe for this question of time, what do you think about Number 5, do you think suction is not needed for this patient? Naftar.
Hello?
Yes,
Do you hear me?
Naftar.
Yes.
Yes, I see the I don't understand the external and
VD.
what? It was external ventricular drain. I don't understand what. But airway equipment, mechanical ventilation is needed, airway equipment is needed, manual ventilator mask is needed, suction apparatus is needed, but I don't. Oh no. I was. I would like to
That's
write
good.
for external ventricular drain.
Yeah, that's good. That's good, Naftar. Thank you.
Yeah, it's not suction apparatus. Suction apparatus is needed, very needed.
Exactly. Yeah.
Yeah, the
Thank you.
ventricular drain is the device used for people who have raised the ICP, then they press that to decrease the PSF and
Yeah.
minimize the ICP. Especially people have either trauma, brain injury, or people have like hemorrhage, things like that.
True.
Okay. Let's click on this. Arana, you can click on the specialist equipment that are needed so that you can see what is recommended. You can go down to, 4 or 5, I think. Yeah, that's it. Yeah. As you can see, there is a big list of equipment which is needed. So you may those may include ventilators for invasive and non-invasive ventilation, hand ventilation equipment, suction apparatus, airway access, including a bronchoscope. That's for high income settings. And also you have vascular access equipment that can include arterial line, like CVP, central venous lines. You have monitoring equipment, both non-invasive and invasive, defibrillator, pacing equipment. Sometimes they're on one machine. You have equipment to control the patient temperature. You have like a bear hugger and the cooling machines. You have chest drain equipment available, infusion pumps, portable transport equipment, because you may need to move the patient to imaging or to other departments. You need specialized beds which can be easily, you can change the position easily. Some patients need sit up, things like that. You need lifting and weighing equipment. Ultrasound, I think ultrasound is important for ICU, especially for line placement, but also to check like complication on the lungs, like pneumothorax or heart function, things like that. So you may also think about having replacement therapy, um, intra-aortic balloon. Those are very advanced. I think we can stop with that. But the key message is that there is a lot of equipment and the resources you need in order to have ICU. So, and we'll see that while we discuss about admission and discharge uh, criteria. So we need to use the resources of ICU wisely because it's very expensive. ICU. We can go back. I don't know. We can go back to the main slides. Thank you. Yeah, and this is really brings us nicely to the next discussion about the indications for ICU. Probably people can just put like two most common indications for ICU for in our settings, for example. You can put that in the chat. What are the two most common indications for ICU admission? And after that, we will ask Jean-Paul and Celestine to give us their experience. Then we will review this article very fast. Okay, very good. Dieudonné said respiratory failure. They agree. I think we have seen a lot of patients with respiratory failure. Someone who is with like a kid and himself. Okay, I think that most of the people think the most important reason for ICU is respiratory failure. Okay. Unconscious patient. Okay. So what would you say is polytrauma patient? Okay. I think that's enough. Let's click on this to see the statistics from US, and maybe Jean-Paul and Celestine will share with us their experience in Rwanda. So you can go down. Yeah, keep going down. Yeah, keep going. Yeah, there. That's good. So as you can see, so the common indication of ICU admission in the US include cardiac, respiratory, and neurologic conditions. So the 5 primary ICU admissions for adults are respiratory failure, acute myocardial infarction, intracranial hemorrhage, percutaneous cardiovascular procedures, and septicemia or severe sepsis. So other conditions may include poisoning and toxic effect of drugs, pulmonary edema and respiratory failure, heart failure and shock, cardiac arrhythmias, and renal failure with major comorbidities, gastrointestinal hemorrhage, and diabetes with complications. And the most technological support is mechanical ventilation, which is required by 20 to 40% in ICU admission. So this is for US, and I don't think we need to go in pediatrics because this is a separate setting, and most of us are not involved in the PQ. So, Celestine, what is your experience in Rwanda? What do you think is the most common indication? But maybe before you start, we did a small study to see the reasons of admission in ICU for obstetrics. And what I have found is that we have seen 69 patients who were admitted for 1 year in 2017. And almost 85% of them, they were admitted for just 2 reasons. The first one was hemorrhage. The other one was post-cesarean section infection and sepsis and septic shock. So we had the other few people who came with respiratory failure and people with preeclampsia. Yeah, but most of the people really, those 2 issues, hemorrhage and sepsis. in obstetrics. That's the data I have, but people can share their own experience as well. Jean-Paul and Celestine, you can go first. Celestine, are you there? Maybe.
Yes, Alain. Yes, Eugene.
Okay.
Thank you very much. So currently, we don't have overall statistics of ICU, cause of ICU admission in Rwanda, but based on experience in the low-income countries, even in Rwanda, we see that most of the reason of ICU admission is respiratory failure, as they said, and sepsis, septic shock, and also trauma. We still have a high prevalence of trauma case, TBI patient, and as you have seen in high settings, the cardiac issues is prevalent for admission ICU. But for us, it's sepsis, septic shock, respiratory failure, and also traumatic brain injury.
Okay, Jean-Paul, what is your experience?
So my experience is not far from what you mentioned. Even the study we did, if you remember, Eugene, we did a study about the ICU where we found that the most common admission diagnosis was mainly yes.
Okay.
I was saying that the most common admitting diagnosis in ICU we found in our study that was first of all was sepsis. The second one was trauma, mostly head trauma, and then when I'm saying sepsis, that include obstetric infection, surgical infection, and other infectious diseases. And again, the other is trauma. The third one, these are the metabolic diseases, like diabetes, DKA, HHS, things like that. Actually, these are the most common one. Sepsis, head trauma, respiratory failure from respiratory or cardiac origin. But as you know, cardiac origin don't have many patients with cardiac condition as in high-income countries. This is what I can add.
Okay. Thank you very much, Jean-Paul. I think we can continue with the right. If someone has any questions, please, you are welcome to write the question in the chat. I think we discussed about the common indication, but the other comment we can make is to make a decision for admission, we need to think about the survival, the chance of survival, because like I see is very expensive, it's very complex, so we need to use that resource wisely and at the highest uh, impact possible, admitting patients who have high chance of survival. Um, that just let us keep that in mind. And there are a lot of scores, including, for example, a patch score, SOFA score, and other scores which can guide us towards the survival rate in ICU. Then that can guide our decision, and we can be able to defend reasons of admission or refusing admission. I don't know if Jean Paul or Celestine has something to add on that.
Agree.
Very good. So let's continue to see the common complications. Yeah, I see you. So the goal is to be able to prevent those complications. So you remember we have Mr. T, who is beginning to look obviously fatigued. He's less awake, he has rapid breathing, and his color is looking more cyanotic. He is asking for help to breathe. So as you can see, the heart rate is still okay, 102. The blood pressure is going down, 97/51. The respiratory rate is 37. The temperature is 37.5%. And SpO2 is 87%, despite giving a lot of oxygen. So what clinical steps should be taken to care for Mr. T? You can put your answer in the chat. What can you do next for this patient? You have 30 seconds to put your answer in the chat. Are you there? I don't see any answer in the chat. What can you do for this patient? The patient is having impending respiratory failure. How will you escalate his? He's on non-paper mask with 15 liters of oxygen. Are you going to give non-invasive ventilation? Are you going to do intubation? Are you going to maintain the oxygen? Are you going to give high flow oxygen? That's not available to most of our hospitals. Okay, mechanical respiratory support, intubation with mechanical ventilation. Yeah, I think that's a good one. So let's continue with the discussion. Then I can go down. Yeah, that's good. So as the ICU team attempt to place Mr. T on oxygen by high flow nasal cannula, he loses consciousness. So after successful intubation, he's placed on a mechanical ventilator. He's now hemodynamically stable and under sedation. Next, the ICU team decides to place a urinary catheter in the internal jugular central line for increased venous access, lab draws, and the monitoring of central venous pressures. Okay, so just keep that in mind. The patient came in impending respiratory failure. Now the patient is intubated, is on a ventilator, you put a central line, urinary catheter, and you are drawing blood. So imagine potential complications which can happen. So you can put like at least 2 complications which are common for ICU patient, keeping in mind is what happened to Mr. T. So you can put that in the chat. And thank you for answering the question very well. So now let's think about potential complications. Just give us 2 common complications. Okay, I see your quite infection. Good. Okay, tracheal stenosis. Okay. Okay, other complications? Yeah, respiratory system infection, yeah, like ventilator-associated pneumonia, for example, that's good. Yeah, while you're answering that, just keep in mind that sometimes in anesthesia, we don't do follow-up of patient after anesthesia and surgery. I think this is a good opportunity for us to sit and think about what happens to the patient after we provide anesthesia. What can we do to minimize complications after anesthesia? Yeah, we can see some of the examples of the common um, issues or complications in ICU, including VAP, ventilator-associated pneumonia, and most of you guys talked about this. So you have central line-associated bloodstream infections. And for our patient, we put a central line, we put on a ventilator, so he is at risk of those two. So deep venous thrombosis and pulmonary embolism, which is common because the patient is bedridden, patient is not moving. Antibiotics resistance. I think Jean-Paul did a study, I was involved, and we have seen a lot of antimicrobial resistance for our common antibiotics. So we have let's unmute someone who is talking. Okay, yeah, we're back. So what I was saying is that our patient is at high risk of ventilator-associated pneumonia, central line-associated bloodstream infections, DVT, and the pulmonary embolism because the patient is bedridden, is not moving, microbial resistance because we use a broad spectrum antibiotics for most of our patients before having a culture and sensitivity. So you have catheter-associated urinary tract infection. And we need always to think about all those complications. So you have over-sedation. We need to think about like sedation holidays, malnutrition, which is a big problem, and post-intensive care syndrome. We watch a small video to show what this is. Medication errors, which is very common. Delirium for our patient, stress ulcers, and organ dysfunction. So those are very detailed complications. We don't have enough time to go through each of those, but just keep those in mind. Yeah. So, and our last talk for today is care bundles. So I don't know if people have, yeah, bed tours is another one. That's very good. So yeah, so the care bundle, we had an article discussing that we have shared, and I would like everyone to write in the chat what they think is the definition of a care bundle. What is a care bundle for you? And then after that, we can see a few examples of care bundles towards the end. And after that, we have a short group discussion for takeaways. So you have like 1 minute where you can write in the chat the definition of a care bundle. Okay, people are very quiet. Okay, very good. So evidence-based intervention which are performed for better outcomes. Thank you very much, Jacinta. I think that's a good answer. Very good. So for me, I think the care bundle is important because if you know that, then it's good. It's easy to measure the quality of care because you can easily observe people. So how people are performing against the care band or the evidence which is there. So it's easy to make progress or to make improvement. But also in order to achieve that, you need to have someone who is in charge for the quality improvement, either in full-time or part-time. So I think this should be a good takeaway from you guys, because now you are part of the people who have that expertise, who can say, oh, are we providing the care according to the current evidence possible? That's what I think people should take away about that. So I don't know other thought from Celestine and then Jean Paul before we show some examples, and then at the end we'll have group discussion and for takeaways and before we close. So Celestine, you can go first. What do you think about this care bundle? How do you think this can be important for our participants? I don't know, we can unmute Celestine.
Thank you, Eugene. So when we talk about care bundle, it is a well structured way of improving the process of care and also patient outcome. Because if you have at least one or 2 to 3 elements you need to provide to the patient, I think it is very important because you provide those elements and then you reassess the patient if the patient is responding, yes or not. I think to follow those bundle, it is really important.
Very good. So, Jean Paul, what do you think?
What I'm thinking about is care bundles, as you mentioned, you all mentioned. So what is needed is that in our setting, in our ICUs, we need also to have those care bundles which is adapted specifically to our setting. Let me give you an example. Like we said about VAP, ventilator-associated pneumonias. There is like 3 component bundles. And again, these are like standardized bundles, which is ready to be modified according to the setting, according to the availability of the equipment. But in the VAP bundles, there are like 3 components. People always they remember about oral hygiene, elevation of bed around 45, and the giving anti-uricars to prevent this regurgitation, things like that. And again, in oral hygiene, some setting they are using different equipment or different substance or medication, or I mean, depending on what you have in your setting. But the minimum of things is patients, they should be cleaned. There is a mandatory cleaning or oral hygiene, even by brushing the teeth, by any way you can do, by using oral chlorhexidine or anything is available in your setting. So what I think about care bundle, we are going to see like central line associated bloodstream infection bundles. I was reading that there are many bundles. There is the CDC bundles, there is the University of Minnesota in the US bundles. So all these are the bundles from different institutions. So what you have to do is to adapt those bundles in our setting and see the applicability of these bundles. That's what I can say.
Yeah, thank you very much, Jean-Paul. So the other thing people can think about in their own practice is, for example, transportation of the patient. So you can easily like have like a guide of how you transport a patient. Because when I was some of the teaching hospitals a few years ago, so you will see someone bringing a patient and like there was no guide. Sometimes they don't even know the patient. They don't have full history, or there is no monitors on the patient. So we need also to like take this opportunity to see how we can change our practice. How can we guide, for example, a safe transportation of patient from my hospital? If because you have the knowledge, you have also the expertise to guide the hospital to develop, for example, a policy of how to transport a patient. So that's one way I think the knowledge from this topic can change our current practice. For example, you can say, oh, you need to have anesthesia, see the patient have like advanced airway, or they will come with anesthesia. You have to have basic monitor. You have to have sedation. You have to have sedation drugs. You have to have vasopressors. You need to be in touch with the referral hospital, things like that. But you may think about like 3 to 5 interventions, which you think as a group can improve the outcome of that particular patient. So we need to find a way to use the knowledge from this discussion to change our practice. Let's continue to see a few examples. This is one example of the bundle of the steps to prevent H1N-associated bloodstream infections. So where you need to wash hands with soap and alcohol, you have to wear sterile gloves and mask and gown. You need to completely cover the patient with sterile drapes and avoid pressing the catheter in the groin. Central lines, and then clean the insertion site using chlorhexidine, and also remove the catheter when they are no longer needed. So that's one example. So let's continue down. See another example. We can skip that. I don't have a lot of experience with that. So, and sepsis and septic shock. I think this is important for all of us because we see a lot of septic patients coming from district hospitals and other hospitals. So, as you can see, the first thing to do is to measure lactate, but it's most of the hospitals we may not be able to do that. But at least we need to obtain the blood culture before we give antibiotics. This has to be done within the first hour. And then we administer the broad spectrum antibiotics. We give a bolus of fluid, 30 minutes per kg. And after that, we apply vasopressors to keep the MAP above 65. So that's another example of care bundle for sepsis. So you can continue down.
So I have a small comment on this band of sepsis, Eugene.
Yes, please.
So when you see this bundle, it has to be done within 1 hour of presentation of the patient. It means that this 1 hour bundle, usually when you you are working in tertiary level in teaching hospitals, it is not really applicable. Most of those patients, this bundle should be applied in a district, even
Health center.
where they are receiving on first attempt the patient. So as on this group, most of us are working in district hospitals. We need really to understand this 1 hour band of sepsis and make sure that if you need to transfer this patient, at least I know that most of districts, they don't measure Lactate, but at least you have a very nice access, IV access. You start fluid resuscitation. You start antibiotics within 1 hour. You take sample for culture, and then maybe you transfer the patient to tertiary level, but at least you have done all of 5 elements of 1 hour bundle. Because if you transfer the patient in the tertiary level, they don't really do a lot of things about this 1 hour bundle. I think most of the things should be done at district hospitals where they receive the patient on first attempt.
Thank you very much, Celestine. People have to keep in mind that every 1 hour delay will be associated with around 7% mortality. So that's why it is very important really to provide this bundle as soon as you see that patient. So I see that Anastasia has raised the hand. So Anastasia, you can unmute yourself and provide your comment. Anastasia? Okay. When he'll be available, he'll be able to give the comment. So the other complication which is common is post-intensive care, post-intensive care syndrome. So let's watch the video to see that complication, and then we'll be able to finish.
Many people now survive critical illness. Healthcare professionals used to assume that patients who survived critical illnesses returned to how they were before. However, stories of patients with profound struggles after being hospitalized emerged, such as James, Maria's, and Ping's stories. James was a businessman. He had sepsis from a severe bout of pneumonia and needed life support for 10 days. For months after his illness, he was forgetful, had difficulty concentrating, and frequently lost his train of thought. James was asked to copy this drawing, and he drew this. Maria was a professor. She had severe influenza. Her kidneys and lungs failed, meaning that she needed dialysis and a breathing machine for 2 weeks. After her hospitalization, Maria had profound weakness. She had to learn to walk again at a rehabilitation center. Ping was in 4th grade when he was hit by a car. After being in the intensive care unit, or ICU, he went to a rehabilitation hospital. Ping talked little at rehab, but learned how to use his arms and legs again. He had a hard time reconnecting with his friends. During the past 20 years, research has confirmed that these types of stories happen more often than not. In 2010, the Society of Critical Care Medicine, or SCCM, gathered together experts involved in the care of ICU survivors. The group named the combination of problems common to survivors of critical illness post-intensive care syndrome, or PICS. PICS includes new challenges to the brain, body, and emotions, and is seen in more than half of critical illness survivors. Children surviving critical illness often have similar problems, such as delayed developmental milestones, learning problems, and sadness. Families and friends are also affected. For example, James' persistent problems led to his wife giving up her job to be his caregiver. Researchers are working to prevent and treat PICS. SCCM believes that ICU survivors can share their stories to help each other, which is why its Thrive initiative is building a network of face-to-face groups for critical illness survivors. In 2015, 6 Thrive sites were launched. In 2016 and 2017, even more will join. If critical illness has touched you or a loved one, please join us. Let's create a better recovery together. More resources about PICS and the Thrive initiative can be found here.
Yeah, this is just an introduction. This is a complex topic, but my takeaway is that we need to go beyond just providing care in the ICU and go beyond and imagine the return of function and also the well-being once the patient go home. Is the patient going back to the community and contributing to the same level as before ICU admission? Because most of the time in our context, we look at the outcome of mortality, but mortality is not the only outcome. We need to think about patient satisfaction and patient function and the contribution to the community. Is the patient going back to their own regular day, their own life? So that's a big question, really, we need to think about. So I don't know if Jean-Paul or Celestine has any other addition on that. In the meantime, Alana can go down to the next slide. Okay. Yeah, for this one, it's just an example of another bundle for like weaning from a ventilator, where you need to provide a good pain management, do a spontaneous breathing trial and spontaneous awakening trial for every day. You choose appropriate analgesia and sedation, and manage delirium and prevent delirium, provide physiotherapy, as we said, air mobility and exercise is important. And then you need to provide family support, involving the family in the care of the patient. So those are a few examples of care bundles in ICU. So before we finish, I would like to do like a group discussion. We have 3 groups. I will have one group, and Jean-Paul and Celestine will have other groups. And we will just ask everyone to give like 1 or 2 take-home messages. And after that, we'll come back and at the end, we will discuss about your certificates and your comments about other topics we need to cover for you, and we answer any questions. So we have just few minutes remaining. So we have just about 5 minutes maximum for the groups, and then another 5 minutes as a whole group, and then we'll finish. Thank you very much. Arana, can you help with like to organize those 3 groups?
It was really interesting and very interactive. And for other topic of obstetric pediatric, maybe we shall discuss together and make a decision which will be communicated soon. Thank you.
Thank you very much. Jean-Paul?
Honestly, what you mentioned, I do agree with your decision, and I think the way we are doing and preparing this teaching session, I think it is very interactive and helpful even for the participants. So I think that we can keep in this way.
Okay. Yeah, thank you. I don't need to take much of everyone's time. I thank you again for your time, for your participation. And our next session will be on June 19. It will not be the end of the month because I have a conference on the June 26th. But I will find a way to do the session on June 19. And the topic is ARDAs, so it will be interesting. So acute respiratory distress syndrome, that will be the topic, and we will send a reminder like 1 week before as usual. So I would like again to wish you a nice weekend, and we will see you in the next session.
Great, thank you. And I'll just add before we log off that if you are interested in obstetric or pediatric anesthesia, although that they may come up later in this course, if you visit the Learning Resource Center, the link will be shared with you by email and in the WhatsApp group. There are a number of resources there if you have some time and you'd like to look at that. So just wanted to put that out as an option as well.
Okay, thank you very much. Yeah. Okay, so we can let all the participants go and everyone. Yeah, thank you.
Bye, everyone.